Hello, everyone. My name is Chinglin Ho, and I'm a glaucoma specialist at the Singapore National Eye Centre. A very warm welcome to what is possibly the most exciting video symposium in our Congress, entitled My Glaucoma Surgical Nightmare. The mastery of a surgeon is truly tested when things go badly awry, unexpectedly during surgery. I believe that all of us will have such moments, big or small, in our surgical careers. The decision-making and our reaction in these critical moments may have a great impact on the outcome. While they may be harrowing at the time of occurrence, a lot can be learned from these nightmares when we study them retrospectively. We are really fortunate to have 5 very experienced glaucoma surgeons around the world share with us some of their surgical nightmares today. These eminent speakers are Dr. Juan Jose Mura from Chile, Dr. Samer Mozet from the US, Dr. Augusto Paranjos from Brazil, Dr. Esther Hoffman from Germany, and Dr. Marlene Moster from the US. I hope you enjoy this very interesting session and have a fruitful conference. Thank you.
We're going to talk today about the Urezza-Valia syndrome following GATT. I have no conflict of interest with the presentation, so we're going to start dealing with the patient. It's a female patient, 46 years old, with the glaucoma diagnosed like 3 months before the consult in my office, with high myopia. She's a contact lens user. The refraction was -12 in the right eye and -10 in the left eye, with the best corrected visual acuity of 0.9 in both eyes. She was using maximal medical therapy with 4 medications, with an important meibomian gland dysfunction and ocular surface disease, and as well as contact lens intolerance. The IOP was 16 and 17 in that moment, and the CCT was 501 and 504 microns of thickness. The CDR was 0.95 in the right eye and 0.8 in the left eye. Both optic nerves are tilted because of the myopia, and the gonioscopy shows a wide open angle with all the structures easily seen during the exam. We propose to do a GATT because of the high risk of complications during a trabeculectomy in a young myopic patient. And as you can see here, we were able to complete a 360 intubation, as we can reach in 80% of the patients when the SLAM is continuous. We observe, as you can see here in that short video, some blood reflux in the anterior chambers. That shows that the system of the collectors and after collectors is working properly, because when the fibrosis and the scarring goes beyond the SLAM, you frequently can observe any reflux, because there all the system is not working properly. That's the reason, because the mix and other surgeries that pointed to the SLAM doesn't work in patients with very advanced glaucoma. After 6 months of the surgery in the right eye, the patient was asymptomatic. The refraction was the same. The best corrected visual acuity was the same. The IOP was 11, using a combination of timolol and brimonidine twice a day, and the rest of the exam was exactly the same that before the surgery. So we decided to go for surgery in the left eye, the better eye. The intubation in that eye was possible just in 210 degrees, because the SLAM was discontinuous, as we can observe in 20% of the population. As you can see here in the video, we tried to go further with the problem, but it wasn't possible, and we opened just the 3/4 of the circumference of the eye. Postoperative day 1, the IOP was 14 millimeters of mercury. The patient has no symptoms the day before, no pain. and the pupil was like, you see there, like 3 millimeters of diameter. In postoperative day 5, the IOP was 14, but the exam in the slit lamp shows a fixed dilated pupil with no reaction to light or accommodation, and synechiae in 180 degrees in the inferior part of the angle. I have no pictures of that visit, but this is the picture of the eye without any drops to dilate the pupil before the surgery. I reviewed the literature and I found this publication about the Uret-Savalia syndrome following a goniotomy in a child. In 1963, Dr. Alberto Uret-Savalia described this disease in 6 patients with wide and rigid pupils, with the posterior synechiae and iris atrophy, but after PKP. The Uret-Savalia usually occurs in just one eye, despite we can go for bilateral surgery. The possible risk factors for the syndrome are increased IOP during or after the surgery, the use of atropine or other mydriatic agents, the presence of keratoconus, viscoelastic material left in the eye, and the anterior chamber inflammatory reaction in the postoperative period. The mechanism is not fully understood, it's probably multifactorial, but the most widely accepted theories are ischemia of the iris and acute rise of the IOP. We went to the secondary surgery. As you can see here, we're doing a goniosynovitis under direct vision using a Mori lens. We're trying to take off there a kind of bar of fibrotic tissue that is inside of the Schlem, and we tried to complete that, but wasn't possible. And I started to use a micro tire to pull gently the iris to break the synechiae. In just a couple of seconds from now, as you see there, I took the iris and pulled very gently, and I separate the root of the iris from the Schlem. As you can see there, I was able to take off this tissue that was, inside of the Schlem, as you see there, as a fibrotic band. I'm taking out of the eye. They put over the surface of the cornea. This is the view with a intraoperative gonioscopy. You can see the Schlem is open with small amount of blood inside of it. That because it's clean, it's no tissue inside, it's not, the synechiae are now open. And after that, I have to complete the surgery doing a pupilloplasty, because the most important symptom of the patient was the photophobia and the very strong problem working outside, because usually she works outside. We complete the pupilloplasty. We left a pupil of 3.5 millimeters. Through that size, we are able to do, the exam of the posterior pole using the wide angle cameras, or the examination of the optic nerve in the regular basis. We clean very carefully all the OVD inside of the anterior chamber. This is the image of the left eye in postoperative day 1, after phaco plus IOL plus goniosynovitis plus pupilloplasty in the left eye. The IOP was 15 millimeters of mercury, and the uncorrected visual acuity was 20/20 -1. The last visit, the IOP was 11 in the right eye and 13 in the left eye, using the same combination of timolol and brimonidine twice a day, both eyes, with no photophobia. If you look at the picture, you practically can notice any difference between both eyes, and the patient was very happy with the aesthetic aspect, and also because of the absence of photophobia was the symptom that has more problems, especially during his hair time work, because she used to work outside. Preventing the syndrome is very difficult because the precise cause of the syndrome is uncertain, as we commented before. It is recommended to have a meticulous clearance of any viscoelastic material and to leave only a small amount of air at the entry chamber when the air is needed. In that kind of surgery, we usually left some air there because we need to have some pressurization of the anterior chamber to decrease the chance of have ifema. I believe that I use an excessive amount of air in that patient that causes short-time blockage of the pupil and IOP raising and iris ischemia, and that was the reason of the complication. I think we have to be very careful with the remotion of the viscoelastic, and especially with the amount of air in the anterior chamber at the end of the surgery, especially if we don't have an iridectomy or iridotomy previously performed. Thank you very much.
Hi, my name is Sameh Mossayed, and I'm a professor of ophthalmology at the Gavin Herbert Eye Institute at UC Irvine. Today, I'm going to be discussing late trabeculectomy surgical revisions with you. I have no relevant conflicts of interest. Well, we all know that trabeculectomies do age over time. Many of these develop Tenon's encapsulation, or that Tenon cyst described as a ring of steel by Peng Ka and his colleagues at the Moorfields Eye Hospital many years ago. And these encapsulated thinned blebs where the conjunctiva is very thin are prone to rupture and leakage over time. Avascular blebs are particularly vulnerable to blebitis and endophthalmitis. There's mechanical breakdown of the bleb that occurs over time. And also, patients who are on long-term medications can have conjunctival compromise, which makes surgical revisions very challenging. The ideal bleb looks something like this, very diffuse. There is vascularity there. It's not hypervascular, but there's lacy vascularization or hypovascularization. And that's because the blood flow brings immune support and integrity and nutrients to the eye. And so you do want to have vascularity in your bleb. Here are some other examples of ideal blebs. Again, they're diffuse. There's no evidence of encapsulation. There is hypovascular lacy vessels throughout the bleb, and they look perfect. Now, these are obviously suboptimal blebs. They're encapsulated, they're avascular. You see they're very focal with thinned conj overlying it. You can see the flap underneath. And these are the ones that are prone to aqueous jets and continued thinning of the conjunctiva over time and are at risk for blebitis and rupture. Factors that lead to encapsulation of these necrotic blebs are focal application of mitomycin C. We now know that a diffuse application of mitomycin C is preferred. Limbal-based trabeculectomies are often more prone to these ring of steel formations. Inadequate subconjunctival dissection also leads to less diffuse blebs. And excessive mitomycin duration or concentration can also lead to necrosis and avascularity. Long-term results of the ugly bleb, on the one hand, you can have overfiltration with hypotony and vision loss, and on the other, you can have scarring resulting in inadequate IOP control. And again, those focal necrotic blebs are prone to blebitis and bleb leaks. So when these come into the clinic, they often look very challenging. Sometimes they have a very large area that needs to be excised and large leaks, and you just think to yourself, how am I ever going to close this? But we have to make our efforts. So I'm going to go through various methods of revising these perforated blebs. First, we're going to talk about a simple conjunctival advancement, the standard revision. Then we'll go through how to excise an overhanging bleb. Then we'll describe an autologous Tenon graft revision. And then finally, a double thickness scleral graft revision. This first case is a leaky bleb with a very focal avascular area. You can see that's leaking. And what I'm going to do here is I'm going to excise the Tenon's capsule, and that's important. You have to remove the entire ring of steel. I'm going to dissect posteriorly here and get a nice posterior dissection. I'm going to try to salvage as much healthy conjunctiva as I can. So anything that has vascularity, I'm going to try to keep it. And then dissect posteriorly as much as possible. I'm going to pull forward to see if I have enough conjunctiva to close it without it being on tension, and then go ahead and remove that entire ring of steel. It's actually very scarred down, as they usually are. And then what's left behind is, of course, a leaky flap that's kind of thinned out over time. You can see that's just leaking, and I'll close it with a few nylon stitches. I think it took about 2 stitches here. And then I'm going to close the tenons and conjunctiva in a running fashion with a 10-0 vicryl. The next one is excision of the overhanging bleb. These look quite terrible, but in my experience, these are very, very easy to excise. There is a plane right under this bleb that you can get under there with a blunt instrument and just get into that plane. It's usually not very tightly adherent. There will be a corneal delin underneath it, and you just lift it right up with that blunt instrument, and you can go ahead and just lop it off. And these will not leak, believe it or not. You imagine this whole thing is just going to open and start leaking all over the place, but they don't. Surprisingly, I'm surprised every time, but you can just lift it right up to the limbus and take your Westcott scissors and just lop it right off, and it is self-contained. It will not leak. Surprise, surprise. So those are pretty easy to fix. The next one we're going to get into is an autologous tenons graft revision. Again, this is a very large bleb, very avascular, and you can see there's no tissue there. That conj isn't even there. It's almost imaginary. The sclera underneath is also extremely thin. Too much mitomycin was placed on this eye, and the nylon sutures just won't close it. As many stitches as I put in, it just keeps leaking, more cheese wiring. So what I'm going to do is I'm going to take a piece of that tenons. It's nice and healthy and chunky. I'm going to pull it over and sew it down real tight to cover and kind of tamponade that leak. And then I'm going to sew it up to healthy tenons and close it with the conjunctiva over with no tension on it. And again, I'm going to close the relaxing incision that I had to make down the side and check it for Seidel. And that's a nice way of closing this incision with autologous tissue you already have on the eye. So no need for any other kind of patch material on this case. This next one is a re-revision, meaning this eye had already been revised a couple times, and there's still a focal area of leakage and very scarred conjunctiva. You see the whole thing is just socked down. So I'm going to go ahead and put in a corneal traction suture. This is a 6-0 vicryl double-armed. And this area has already melted a couple of patch grafts. What I'm going to do is I'm going to open up the conj, which is very tightly adherent. I don't have a lot of room for play here. And I'm going to take a double thickness patch graft. So that's a scleral patch. I'm going to fold it in half and make it nice and thick. And what I'm going to do is I'm going to leave it very large. We can go back and just look at that a little bit again. I'm going to leave it large so that I can sew it down to healthy sclera underneath. If I tried to sew that down to just the area of thinning, there wouldn't be enough scleral integrity underneath to sew it. So what I do is I leave it big so that I can sew it down to sclera underneath that has integrity, and I make it nice and tight so it's a pressure patch. So this is a double thickness scleral pressure patch to tamponade the leak. And then I close the conj over it. And I've used this method several times, and it has been quite successful. So if you can leave your patch graft nice and large, and that way you can really use it as a pressure patch to kind of tamponade a leak and close that on top. So just checking again here to make sure there's no leakage through the conjunctival incision. And this is what this double thickness patch graft revision can look like about a week after surgery. So they're very, very effective. Other patch graft options you can use are conjunctival autograft, or even tarsal conjunctival grafts. You can do pedicle grafts. You can use donor cornea, amniotic membrane in my experience. tends to fall apart after about a week or two. It's not my favorite, but in a pinch, you can use that. Keratolimbal allograft comes with the limbal stem cell, so that really integrates nicely into the tissue. It's a very nice graft material if you can get a hold of it. Donor pericardium, and there are other patch graft options as well. So in summary, trabeculectomies do age over time, and they do come with about a 1% per year risk of phlebitis and endophthalmitis. The thin-walled, avascular, encapsulated blebs are the ones most at risk. So we have to continue to be vigilant for leaking blebs and Seidel test them on serial follow-up visits. And also to remember those eyes who have a trabeculectomy when taking care of other ocular comorbidities, to remember that there's a trab up there. So be careful when putting in a speculum, when doing things like intravitreal injections for AMD or CME. A lot of these automated blepharitis treatments now can traumatize a bleb. I've seen several patients that have gone for cataract surgery, and the surgeon has used femtosecond laser and ruptured the trabeculectomy when doing the docking. And other conjunctival manipulations. We have to be really careful in eyes with trabeculectomies, old or young. So as glaucoma surgeons, we're always on call for these patients whenever they come in, and we have many different methods to repair a leak. So happy plumbing. Good luck.
Hi, everybody. My name is Augusto Paranhos. I'm from the Federal University of São Paulo, and I'm going to show some interesting surgical case that we're going to call a nightmare case. Those are my disclosures, nothing related to this presentation. And let's start with the nightmare itself. Well, this is the clinical case. It's a 7 years old female bilateral chronic angle closure glaucoma with a plateau configuration. The IOP was 20 with 3 medications, and it was planned to underwent a focal trabeculectomy in both eyes. This is the phacoemulsification itself. There's nothing very special with this phacoemulsification. The only thing that we have to be careful is that the anterior chamber is a little bit shallow, so we have to take this in account when you do the phacoemulsification. And the phaco itself was very smooth, so no problem on that. And I had the chance to remove everything with no problem at all. In the video, so everything was okay, and now finishing the aspiration. Okay. And now to insert the lens with also no problem. And you're going to start to do the trabeculectomy. The thing that we do is everything with local anesthesia, and when we perform the trabeculectomy, I like to do subtenion anesthesia, so I have full control of the eye. There's no problem that there's no pain. We use together with the subtenion anesthesia. I like to ask for propofol for that. This is the anesthesia, the subtenion anesthesia. And here, cutting the conjunctiva to perform the trabeculectomy. The trabeculectomy, there's nothing very special with the trabeculectomy in palatal iris configuration. The only thing that we have to be careful is to avoid any chance of a misdirection after the surgery. So I'm going to show how I do prevent the misdirection after the surgery. So I like to use a small flap, and here to continue the cutting the lateral of the flap. Mitomycin C. It's again a normal trabeculectomy. That's moving fast, a little bit faster. And here's the trabeculectomy, the rhidectomy, and I slit now to see how the anterior chamber behaves. So it's maintaining the anterior chamber. And the second suture, I like to do a removable suture. So I have a better control of the pressure in the first days of the surgery. Okay. And here is finishing the surgery. So again, it's a straightforward trabeculectomy. That's showing how I close it. So it looks a very, very nice phaco trabeculectomy with no problem at all. Looking for the angle, how it looks. So everything is okay in this patient. And this is the first IOP, first day of post-operative day. So the IOP was 12. The anterior chamber was formed. And the third day is 16, and with message, it goes to 11. 1 week, it goes, the IOP was 18, and I decided to remove the removable suture, and the IOP was 9. At the 12 days after surgery, it was again 18, and the second stitch is removed with laser. It was 10, and it looks perfect. And 2 weeks after the surgery, it was 9 millimeters of mercury, and the visual acuity was 20/20. Now, I like to show something different with this case. This patient has a wife who called almost every day complaining that her husband was blind. I opened the office to see at night, at the weekends, and nothing was going on. The surgery was perfect, and it happened several times. Until one day that the patient himself called me, and he said that it was serious, that he was not seeing even the light. So I was worried about that. And I remember the fable from Aesop, the boys who cried the wolf. So everybody has this kind of patient that complains a lot, and sometimes you decide, oh, it's not true, but it was. Let me show you the 5th day after surgery, after he complained about just light perception, and this was what we can see in the microscopy for this patient. So again, you can see the choroidal. You cannot see anything from the back of the eye, just choroidal. And we perform ultrasound. You have to do that to see if it's hemorrhagical choroidal detachment or just serous choroidal detachment. It was a serous choroidal detachment with kissing choroidal. So you have to do something. And here is how you perform the surgery. And interesting thing is, first of all, you need a maintainer for the anterior chamber. And whenever you have to work on the inferior quadrant of the eye, because you have a trabeculectomy at the first, at the superior one. So I like to do a flap, an incision. There's no way that you can touch the retina in this place, because the detachment is so important that you can work very freely with your knife here with no problems. And at the beginning, you put the anterior chamber maintainer, and then you start cutting. And you're gonna see this yellow fluid coming from your incision, and looking for in the pupil, you're gonna start seeing the red of the retina coming. So it's a very good view because you have a clear idea that everything's going to be all right. Now you're going to see a lot of this fluid coming, then start coming some blood. You have to do cauterization to keep this a little bit open. There's no problem to keep this open because every time, if you still have some fluid to come out, you can do that. It just come out from this incision. And you can see by the pupil that the retinal reflex is very clear. And now you just have to close it. And at the end, everything was okay. I like to leave this bubble because you need a little bit pressure in the eye. Remember, there's a trabeculectomy. And at the end, the final ultrasound was, everything was retouched, and the patient was happy. His wife was never happy. I think that his wife was somebody that has some issues, but the patient was happy. The vision was 20/20, and the other surgery from the other eye was perfect with no retinal detachment. This happened because the patient had to carry some groceries from his wife, and that's why she has this problem. He has this problem. Well, that's it for today. Thank you very much. I hope you enjoyed the nightmare.
Good afternoon. I would like to share with you my glaucoma surgical nightmares. So what are you seeing here? This is a 3-year-old boy after probe trabeculotomy 4 days ago. This boy had an advanced congenital glaucoma on both eyes. I performed an uncomplicated probe trabeculotomy 4 days ago. The child was discharged from hospital, had a flu, was coughing, and had a painful eye. After that, the parents came back to the clinic with the boy, and what I saw was the image before, an intraocular bleeding. So horrible. What did we do? I waited for about 10 days until liquefaction of blood, and then I performed a sclerotomy to release the blood out of the eye, as you can see here. And there was a lot of liquefied blood coming out of the bulb. More and more blood. And at the end, the bleeding stopped, and I sutured the sclera tightly and hoped for the best. In the follow-up, the intraocular pressure of the boy stabilized in the lower teens, and also the eye over the first months. And the visual acuity was hand movement in the beginning. But then he developed diphthesis, as I expected, about 12 months later, and now the eye is blind. So I lost one eye of a 3-year-old boy. So what happened? The boy had a suprachoroidal hemorrhage, that is a rupture of the ciliaris posterioris, longae brevis, or the vortex veins. The incidence is quite low, but there are risk factors such as age, myopia, MEN, postoperative hypertony or anticoagulation, and also congenital glaucoma. If a suprachoroidal hemorrhage happens, the prognosis is very poor and there are no guidelines for treatment. Fortunate, the other eye could be saved with a glaucoma drainage device. I will share with you another nightmare. A 70-year-old patient came to me after trabeculectomy that was performed in another hospital. She had already undergone several revisions due to conjunctival dehiscences, and a diagnosis was also that she had a mamma carcinoma with chemotherapy and radiation 12 months ago. she presented with new conjunctival dehiscences. This was the case after trabeculectomy and several holes in the conjunctiva, and the sutures teared through the conjunctiva. First of all, I tried a conjunctival patching, as you can see here. I performed the tight suturing of the conjunctiva and tried my best to close it. But after 2 days, this patch teared again, and I performed another patch. And also, this did not work. So there was again a dehiscence of the conjunctiva. And I performed a third patch, including a amniotic membrane, but the Seidel test was still positive. The pressure was low, and the lady showed a hypotony maculopathy, and visual acuity decreased. So I had a problem. I decided to wait and not to perform more and more surgeries. I waited, including a contact bandage lens. And I waited for about 3 months under antibiotics. Under this contact lens, and only watching and seeing the patients every 2 weeks, there was a slow increase of intraocular pressure over time. And after 3 months, fortunate, the pressure was 14, she had no choroidal folds, and visual acuity was 20/40. So the wait and watch strategy versus a surgery was probably the better solution. Well, in conclusion, glaucoma surgery sometimes can be very, very cruel. A transparent communication with the patient, and in case of the boy, with the parents, is very important to tell what happened, perhaps to explain why it happened, and to explain why not to do anything more. Nightmares are rare, fortunate. I thank you very much for your attention.
Hi, everyone. I'm Marlene Moster from Wills Eye Hospital, the Glaucoma Service, and we are located in Philadelphia, Pennsylvania, in the United States. I'm very honored to speak to you today about our worst day in the operating room, and this comes from Wills Eye Hospital. Here are my financial disclosures. None of them are relevant to today's talk. Now, this surgical nightmare started as an ordinary day in the Wills Eye ASC. It was the second case. The cornea service had previously asked the glaucoma service to help with a difficult case. A 79-year-old man fell on the edge of his living room coffee table while bringing his wife a TV dinner. He had an open globe injury. He split his cornea, and his old implant was extruded from the eye. Primary closure was done, as well as a vitrectomy. He healed, but lots of scar was in place, and therefore he underwent a corneal transplant. This was uneventful, but unfortunately, the PK had failed. Because the retina was still thought to be healthy and the eye still thought to have good potential vision, a K-Pro was planned in conjunction with a Barvell tube shunt because the intraocular pressure was 45 millimeters of mercury. So he was scheduled for a combo case. This was the second case of the day. And as we always do, the glaucoma team goes first. We take the Barvell tube shunt, we place it supratemporally under the muscles, and it's always decided, if possible, to tuck the tube in so that after the K-Pro, it could be decided which is the best place to localize the tube shunt for the most efficacious result. So we put in the barbell plate, put the tube away so that the cornea people could sit down and start the K-Pro. As often is the case, the glaucoma people then go to the break room for a cup of coffee. The cornea people now are in charge. Here you see the cornea so scarred, and the cornea doctor is doing the tree fine so that the K-Pro can be placed. Commonly, a vitrectomy, an anterior vitrectomy, goes along with this, but the cornea doctor does not realize what's going on in the back of the eye. Look at what is happening. The cornea doctor does not realize this. His head is turned. He takes the K-Pro. He asks for the 10-0 nylon. The surgical scrub nurse is giving it to him. He's getting it in place. While this is happening, look at the choroid.
Oh, fuck. It's gone.
So now the only thing left to do is to try to put the ocular contents back in place and sew the K-Pro on. But you and I already know that the visual prognosis for this eye is very poor. And in fact, even with a nice anatomical closure, this eye went on to no light perception. So when should we expect this? In eyes with prior trauma, in open globe cases, in patients who are hypertensive, on blood thinners, and the elderly. You need to be aware that this is happening because unlike other complications, the surgeon is caught unaware, unprepared, and quite shocked that this is happening so fast. Expulsive hemorrhages should not be like downhill skiing, where fearless risk-taking is what gives the ski race its sizzle. We don't want that. What we want is calm control. What you do is when you notice this is happening, take your thumb and squash it down right on the wound. When I was a fellow, my first day in the operating room with Dr. George Spaeth, 2 cases were like this. Each time he took his big thumb, squashed it right on the wound, and ordered me to close the wound at that time with 9-0 nylon so that the wound would hold. Each time the eye was saved and the contents was not extruded. So who is at risk? First of all, so many of our patients are on anticoagulant therapy. Over 12 million people in the United States have atrial fibrillation, making many, many millions of patients basically ordered to take anticoagulants to avoid stroke and thrombotic phenomenon. Now, spontaneous choroidal hemorrhage associated with oral anticoagulants are rare, but well reported. The newer drugs, which are alternatives to heparin and vitamin K antagonists, include Xarelto and Pradaxa. Special monitoring should be performed in patients on these newer blood thinners, meaning that they should be made aware that there's an increased risk of any kind of ocular surgery. Even though a meta-analysis shows that the risk of intraocular bleeding is reduced by 22% on the newer drugs compared with warfarin or Coumadin, one must be aware that this is still a possibility. Other people at risk are those with advancing age. In 2019, in the United States, 6.7 million people were over the age of 85. Therefore, these patients are more at risk under any circumstances while having ocular surgery. In addition, patients who have glaucoma have an increased risk of developing an expulsive hemorrhage, largely because the intraocular pressure is elevated and oftentimes not well controlled at the time of surgery. Currently, about 3 million Americans have glaucoma. Half do not know it, and 70 million people worldwide are afflicted by this disease. Therefore, good communication of the possibility of a large expulsive hemorrhage should be made between the residents, the attendings, the fellows, and the patients. And lastly, another risk factor, which it seems everybody seems to have, and that is hypertension. 45% of all the adults in the United States do have hypertension, but only 1 in 4 adults, specifically 24% with hypertension, have not this under control in spite of using medication, and that is because compliance is poor across the board. So therefore, be aware that an expulsive hemorrhage is happening. Act quickly and put significant pressure on the wound. Do everything possible to try to save the eye and make this a win-win situation. Thank you very much.
Congratulate you on your brilliant presentations. Indeed, it's inevitable that at some point in our surgical careers, we'll encounter unexpected surgical challenges such as these, and sometimes even disguised as home runs that will require us to pull out all the stops in order to secure a favorable outcome. Thank you for your marvelous work in managing these nightmare scenarios and for sharing your incredible expertise, skills, and experience with us. So now we have questions for the speakers, and I think we will start with Dr. Juan Jose Mura. I think you've already answered some of the questions on the Q&A. Actually, I have a question to ask you as well. Did the patient you saw, did she have was she symptomatic at the time that you discovered the fixed dilated pupil? Because you know, with the 360-degree PAS and such a huge pupil, she might have photophobia or signs of increased intraocular pressures because of the angle occlusion.
The pressure was never high. You know, the pressure was always normal. And, you know, she's a very good patient. That's the worst part of everything. You know, always the best patient has the complications, and that's a nightmare for itself. You know. Yeah. The patient the first day has no problem, was the same evolution of the first eye with no pain. But after that, in the control of the 5th day, she knows the pupil was enlarged. And that was the only symptom that she has. The nightmare started there, the 5th day after the surgery.
But that was beautiful way you manage it with the pupilloplasty and synecholysis. I've actually had a similar case in a child, actually after 360-degree suture trabeculotomy. And it happened after a huge hyphema, and even after the precipitous evacuation of the clot, this happens. And it shows that sometimes it may indeed be due to high pressure and subsequent ischemia. Okay, I think the other question that I think you have answered regarding the post-op anti-inflammatory regime that you use, and you usually combine an NSAID with steroids, is that correct? To treat
yeah, that's right. I combined both.
Right.
And also the second day, the first day post-op, I started to use pilocarpine 3 times a day for 2 weeks, and then twice a day for 2 weeks, and then once a day for 2 weeks. Because of the risk of synechia after that, because of the hyphema, you know.
Right.
But that patient has a little amount of blood inside of the eye at the second day. But
right. Okay, thank you, Dr. Juan Jose Mora. And we'll go on to Dr. Samir Mose. I think there were some questions for you as to why you prefer to use a double-layered patch graft rather than a single-layered patch graft. And the second question is, do you do tenonectomy in trabeculectomy?
I do not do tenonectomy. I leave the tenons, but I dissect very widely underneath the tenons, both posteriorly and side to side. And then I make sure that I incorporate the tenons into the closure at the end so that it's not kind of pushed back and then it scars down and causes a tenons encapsulation. So I don't do a tenonectomy. Tenons can be your friend, actually, and help you prevent very thin-walled avascular blebs. As far as the double thickness patch graft, those are for cases that have repeatedly melted and leaking still after 1 or 2 revisions. And those are typically in patients who have the need for chronic steroids. So these were corneal transplant patients. They're on chronic steroids, so they keep leaking. And I think that giving the double thickness allows for a little bit more tissue integrity. And then you can push it down when you're sewing it to the sides of the sclera that still have some thickness. You can really use it as a pressure patch. Whereas when I sometimes use the single layer, it's just not, it doesn't quite do the job of a pressure patch.
I tend to agree with you because I do use double layer patch grafts as well, even in repair and in tubes and in repair of labs that are kind of the cornea or the sclera has come somewhat melted. So this is, I think in this scenario, actually a double patch may actually work better. I don't know about the rest of the panel. Do you feel the same?
yeah.
No, we'll go on to Dr. Augusto Paranjos. I think there's some question, somebody asked you whether you would consider using a Kelly's punch and leave a draining sclerostomy after you've drained the choroidals. Do you ever do that? Or do you just leave them after you've actually diathermized the opening to leave it a little bit gaping?
Sorry, I didn't understand the question.
Okay, the question, I think quite a few voted for this question as well. Why don't you use the Kelly's punch and leave a little draining sclerostomy at the site where you perform the drainage?
But you can, you know, whenever you see this, the description of how do you manage the choroidal detachment with the kissing, I think that you just need to act when it's a kissing choroidal. When it's not a kissing, you just have to wait. We perform a randomized clinical trial showing that doing oral steroids make it worse. It takes more time to resolve. But whenever it's a kissing, you have to do something. If you do whatever you do that make it open, it's okay. I think it's easier and safer just to use the way I made it. So I do the coagulation close to the incision that keeps it open. The Kelly punch, I think, is too much, and I don't need to make it open for many days. It's just for some days, and it'll be enough. I think that I've never done with the Kelly punch. I think you don't need to do that.
Yes. And do you kind of like during the drainage, do you actually put in pressure internally in the eye with either AC maintainer or putting
that's what I've done. I always put a maintainer in the anterior chamber. So you pressure the eye while you're doing that. You pressure the eye and you move the fluid out of the eye.
Thank you. The next question is for Dr. Esther Hoffman. I think somebody asked you whether, I think you've already answered the questions.
Yes, I did actually question whether there is any radial incision or a tangential incision for the drainage. And so I think it was probably not seen well. So I usually do a tangential incision, but it is very important preoperatively to have an ultrasound. I think that's also what I wrote, to have an ultrasound and to check for the largest bubble or hemorrhage, and then to choose this region to do the sclerotomy. So then you have the most effective drainage out of the eye because of the most blood you can get off. Yeah, and I usually also use the AC maintainer actually, because you can't go past planar, and this is the best option, I think.
Yes, I think, okay, that's great. And then I think they also asked if you perform telanectomy, but I think in general we try not to do that. Okay, so the next, yes, do you have some comments on that? Okay,
I completely agree with Sameh that the tenon is my best friend sometimes, and you should not cut it.
Yeah, especially in that case when you had difficulty closing the conch with multiple, cheese wires in the child. In fact, some of the times I try to actually stitch down to the sclera and come back to fight another day rather than, just walk around with the conch, which is really dehisced. And then the next question is actually for Dr. Marlene Mostad.
Yes.
And I think somebody commented that they had a case of expulsive hemorrhage after implantation of the intraocular lens, and whether you have any advice in that kind of scenario as opposed to an open sky kind of surgery.
In that case, you have to close the eye very quickly to make sure it's not going to turn into an expulsive hemorrhage. I consider cutting down 3.5 millimeters back from the limbus, like we talked about, opening up the sclera, getting to the choroid, getting as much liquid blood out to deepen the anterior chamber. I'd give them mannitol at the same time to deturgest the vitreous, and then I would wait. The most important thing is to have this eye closed quickly and efficiently. But when the cases start high, and we do this all the time, I always do a paracentesis at the beginning of the case and make sure the pressure is about 20. Even if we start at 40 to 50, I think it's critical that we maintain an even pressure as we enter the eye.
I think the last question, we just have a few seconds. The last question will be that, would it have been contraindicated in the patient that had expulsive, because was it contraindicated to do an open sky surgery in somebody with uncontrolled pressure of 45 millimeters mercury?
There's risks every time you go, and certainly with mannitol, there is a risk of an open sky. The pressure was elevated and the Barvelt was placed. That was the decision.
Yes, Dr. Mora, do you have some comments?
Yeah, don't forget the pain. Don't forget the pain. It's a risk factor for expulsive hemorrhage. It's
totally
very important to treat the pain. Totally. When you have pain, you have more risk for
yes. And the last question, and the next one I think to address will be that, will you all stop anticoagulants prior to glaucoma surgery?
No.
No.
How many of you would and how many of you won't?
Well, I would.
You mean? Sorry, the question again?
The question was that, would you stop anticoagulants prior to glaucoma surgeries?
Yeah, I do that. It's most of the times you don't need to. There's no problem to take this off. The only thing that you should not do that by yourself. You have to talk with the person that gives this prescription to understand why is that important. So I think that I try to remove. If I cannot do that, I try to do a micropulse stand of trabeculectomy, for example. But I always talk with the physician that gives this prescription.
I think our time for the session is up now. I hope you've all enjoyed this video symposium. Yes, Dr. Mura, you want to give a last comment before we stop?
A question for all of you. How many of you use the mitomycin inject instead of using the sponge to improve the shape of the bleb?
I've always used a sponge.
Oh, this is a sponge.
You have to start to use
Sponge.
injection.
Sponge.
No, you don't use those sponges anymore.
Sponge no more.
Thank you so much for all of you for your participation, and enjoy the rest of the conference. Take care and goodbye.
Bye-bye.
Bye-bye.